So there are a number of possible scientific explanations for this, which could relate to differences in the limit of detection for the different tests used, how sensitive the test is, the difference in sample types used for the different tests, and also other procedural issues or differences in the specificity of the test, i.e. when you have a positive, how do you confirm that that is a genuine positive? So just going through these in order, the differences in limit of detection between tests will occur. No two tests will have the same limit of detection to detect a small level of RNA. And I think that's probably what we're talking about here from review of results, is very small levels of RNA that have been detected in one test, but not been detected in another test. And that can happen, and the differences between tests' limit of detection are magnified at these very low levels of viral concentration. These low levels of viral concentration may or may not be clinically relevant. That's another matter to consider. There is a certain threshold or a certain limit below which the level of virus may be considered insignificant. The other question is about samples. The swabs sent to Synlab require a swab of the back of the nose, which means going right back to the back of the nose where that meets the top of the throat. The swabs that we have been running in the public health lab have been up to date been throat swabs. So it may be that, again, if you have very low levels of virus present, that you may detect a virus at one site but not at the other. We generally don't think that's the problem when you have high levels of virus present, when you'd expect to find it in the nose, the throat, the saliva, and elsewhere in the respiratory tract. Thirdly is the issue around specificity of the test. That is, if you detect a signal in a test, is that genuinely what you're looking for? In this case, is it genuinely COVID? We're very confident in the specificity of our test, our screening test, performed at the public health lab. After it detects RNA, it will then secondarily perform a MELT step, which confirms that that RNA is specific for COVID. And after that, any positive that we detect in Gibraltar, be it at the public health lab or at St Bernard's, is sent to the UK for another procedure called whole genome sequencing, where the whole genome is sequenced, looking and compared to confirm that that is COVID, and also looking at any subtle variances or mutations in the virus. So overall, we're very confident that when we get a positive with our test, it is positive. We're also confident that the test that we use for screening has an appropriate threshold for a screening purpose, which is different to the threshold that would be used for a test that's used for diagnosis of COVID. And that, I think, also may explain the differences here.
So what are the different purposes of screening and diagnostic tests? Under what circumstances is a diagnostic test used to back up a screening result? And is this also done at the PH lab?
Okay, so diagnostic and screening tests will have different characteristics. When you're running a diagnostic test, you want to pick up almost every last scrap of target RNA present in the sample, and that may translate to as little as sometimes even one copy of a gene. If you have somebody who's symptomatic, that is all you need to confirm that their symptoms are due to COVID. When you're using a test for a screening purpose, which is usually done on a well person in the community who doesn't have any symptoms, then really you are really looking at specificity, which is that if you find a positive in a well asymptomatic patient, is that genuinely COVID and nothing else? There are other viruses that are very similar to COVID in their structure, and you don't really want to label someone as COVID when they actually have something else. So our screening test is geared more at a very, very high specificity, and we accept that there is a trade-off in terms of the sensitivity for very low levels of virus. We want to detect people who've got high levels of virus shedding in their throat, in their nose, and to know that what we find is actually genuinely COVID, where we are, from a point of view of preventing transmission in the community, very, very low levels, a single gene of COVID, which may be on a fragment of RNA and not a whole virus, may actually not be clinically relevant. In fact, it may be unhelpful to find very, very trace elements of RNA, because you might find that in recovering patients who are no longer infectious. You might find that from contamination from environment and end up with unnecessary quarantine of patients. So it's finding the sweet spot for different tests. In answer to the second part of your question, in this case, there was a discrepancy between the assays, and we did run a diagnostic test ourselves on the samples that we had in Gibraltar. We obviously don't have access to the samples that are in Synlab. And on those samples that we ran again in Gibraltar, on our diagnostic PCR test, the same one that's used in the laboratory at St Bernard's, we found that only one of the 15 Kosovan footballers came up at a very low level of detection. Another one came up at an equivocal level. In both cases, these levels were so low that they would have triggered another confirmatory test to confirm whether they were genuinely positive or negative. So as my scientific analysis of the situation is that the levels of RNA present or detected at Synlab and present in these footballers might have been at a very, very low level if they were genuinely COVID related.
And in terms of the different thresholds between diagnostic tests, is this the case between Synlab and ours? How confident are you in where the threshold is set here, and that we aren't missing any positives that we should perhaps be catching?
So the thresholds that we've adopted for our diagnostic tests, and we have more than one diagnostic test at our disposal at St Bernard's, are those that have been discussed internally and also with colleagues from Public Health England, colleagues who use similar tests in the NHS and have vast experience with use of these tests in the NHS. And we have, if anything, in the GHA, set more conservative thresholds for these tests than are used sometimes in the NHS, for instance. So I'm confident that the thresholds that we've applied, and the fact that if we do have a low-level positive, we go on to run it on a different test to confirm it, are in line with good laboratory practice locally.
So we know the screening tests use throat swabs. Does diagnostic testing for COVID-19 in Gibraltar include both nose and throat swabs as a rule?
Diagnostic testing uses a combined nose and throat swab from obviously the back of the throat, but also the back of the nose, the nasopharynx. And that is the test that is recommended for diagnostic purposes. For screening purposes, we pragmatically moved to a throat swab alone, as in for screening, as I've mentioned, we are intent on detecting high levels of virus. Because those are the individuals who are the so-called super shedders or super spreaders, those in the community who are most likely to spread virus to others and pose the biggest risk. And that is what we want to find through a screening program, either by use of the test and by use of the samples. So we pragmatically adopted a throat swab. I think, though, these procedures are always under regular review, and in the context of rising numbers locally, then I think we have already been debating whether we switch to a throat and combined nose swab for screening in addition to diagnostics.
So a question that has been asked quite a lot: if the difference in turnaround between the diagnostic and the fast screening test is just a matter of a few hours, couldn't it be argued that it's better to have a more accurate picture to prevent the spread of the virus in the community?
Yeah, I think there's a kind of a sweet spot to be found between test sensitivity, specificity, and turnaround time for screening. Yes, you could use an ultra-sensitive test that picks up every last scrap of RNA and takes 4 or 5 hours, but that will have a knock-on consequence in those individuals who are most infectious, still wandering around in the community and spreading virus when actually you want to identify those as quickly as you can in order to get those individuals, ask those individuals to quarantine and also identify their contacts and quarantine their contacts. So for a screening program, turnaround time is highly important. I'm not saying that sensitivity isn't, it is, but it's an acceptable level of sensitivity. We know our LAMP test has an excellent performance in detecting those that are high-level shedders, well above 90%. We're talking well over 99% in detecting those who carry a high level of virus in their upper airways, and that is what we need. And it's also highly specific, as I've mentioned, is if you find something on the LAMP test, it is, you know, near on 100% likely to be COVID as opposed to any other related virus. And for these reasons, the screening test approach that we use uses, we feel, the best test for that purpose.
And Dr. Barty has said that false negatives are a problem for all PCR techniques worldwide by as much as 25 to 30%, nearly 1 in 3. We've heard that Gibraltar tests are 90% effective or more. How can those figures be squared?
Yeah, I think there's figures being reported in the press, the scientific media, about a 25-30% issue with false negativity. But I would say that represents an issue for detection of COVID across the entire episode of illness of an individual. We know that as a virus, as an infection, COVID virus levels will vary throughout the course of an individual's infection, be it whether they're symptomatic or asymptomatic, and in their distribution from the lungs to the throat to the nose to the saliva. And it depends when the sample is taken in that individual's illness, that dictates whether you might get a positive result or a negative result. So that figure is the overall sensitivity across an individual's illness. When we talk about a test specifically, we talk about analytical performance. And the analytical performance is the ability of that test to detect the target in that sample, as opposed to in an individual over the course of a 2-week period. And that is where the difference arises. So our tests are highly sensitive to pick up the COVID in a sample, but other variables come into play when you're looking at the whole illness. As I've mentioned, there's also differences in sampling. How good the sample is, that will also affect the ability of the test to detect COVID in an individual. So whole population-based screening for COVID is actually something that many countries aspire to, but something that not many countries have been able to deliver. So I think in that respect, Gibraltar, having employed a whole population-based screening, or a fragment of the section of the population-based screening, to be more precise, has been ahead of the game in many respects. The screening program is also only as good as the contact tracing program you attach to it, and we're fortunate in Gibraltar that we have managed to set up both. Population-based screening has been looked at in detail. I can say in the UK it's been looked at in a lot of detail, and in my capacity, in my role in the UK, I'm involved in population-based pilots in nearby cities near where I work, and also in more wide-scale pilots that are being commissioned by the Chief Scientific Officer and the Cabinet Office. And of interest, the screening tests that are being used for these whole population-based screening programs are being looked at are LAMP tests, because they offer the high turnaround, the quick turnaround time rather, and the high specificity and the high sensitivity for those who are high shedders that are required of a screening test.
And what about our facilities, those in the ROC? How do our screening and diagnostic labs compare to those in other countries?
In terms of our diagnostic laboratory service, from our starting point in January, where we only had one PCR machine available to us, we now have 4 different methods to diagnose COVID in our patients. And those 4 methods use different technologies. So we have a bit of resilience in the system. We've also got a cohort now of highly trained and skilled scientists. We need more, to be honest. We need more in order to improve our resilience, but we have some very able and skilled local scientists, and also scientists we have recruited from abroad who are supporting our diagnostic efforts. So I'm very confident in the personnel and the technologies that we are using for testing in the GHA.
And in terms of test turnaround, what are the capacities of the diagnostic lab and of the screening labs?
Okay, so currently for diagnostic tests, we're looking at somewhere between 150 at a push around 200 diagnostic samples can be run per day. And then in terms of the public health lab, again, we're looking at between 300 and a push 400 samples that could be turned around per day. And we often do, of late, our testing numbers across both labs have been in excess of 600 on some days, which is no mean feat, really, for the GHA. I think with further resourcing in terms of staffing resource and also an expansion of some of our analytical platforms or equipment that we're looking into, we could yet push that higher.
And aside from the question of testing, how important is it to adhere to public health advice on the matter of social distancing, hygiene, masks, and so on?
Yeah, testing is important for diagnosis, for controlling, for identifying those who have it and those who don't, and to inform public health strategies. But the testing solely will not control the spread of COVID. The single most important intervention that we have identified to control the spread of COVID is actually social distancing and adherence to public health measures. I cannot emphasize the importance of that enough as the means that we currently have available at our disposal to control the spread of COVID within a community.